Thank you so much, Libya, as well as Noemi and Mary for including me in this. I'm going to talk a little bit of psychosocial aspects. And just as background, I am Associate Medical Director in Vitas Healthcare, which is a hospice company, and prior to that role, I was the first palliative care physician in Baptist Health in Kendall Drive. So I recently had the opportunity to have a patient with gastric cancer. It was in February. And not only in cancer specifically, but patients with chronic illnesses, inevitably, there's great work by a psychiatrist, Dr. Kubler-Ross, and she studied the end of life in great detail, and she really nailed it with the different types of responses that we have when we go through this. And it's denial, anger, bargaining, depression, and acceptance. You can definitely categorize all of our patients and families in some sort of this stage. And I can see it right there, perfect. This patient was very angry, very, very angry. And I started in hospice in September, and it's been the most difficult case that I have had. I'll give you a little bit of history. He was in Mount Sinai for a month, and he was being seen by Vitas staff in Dade County. And they wanted to directly speak to a director in Broward because his family lived in Broward, and he had a great desire to be at home. And you can only fathom to understand that after being a month in the hospital. So his main complaints were nausea and vomiting and pain. He's 50 years old. This isn't supposed to be happening to somebody at this age, but unfortunately we see it, and it plays into the mood that he was in, definitely. He was healthy before he was diagnosed with cancer. He was diagnosed in July of 2017. And he did fairly well with the first cycles of chemotherapy, but he underwent a fourth regimen, and that really knocked him out. He stated that after that treatment, he was having a lot of nausea and vomiting, and it was coffee ground, and that's what brought him into Mount Sinai. So immediately when I hear of this patient, the fact that he's been in the hospital for a month really gathers my attention. I wonder, how stable is he? Can we transfer him? Can we align ourselves with his goal, which is to be at home? He's alert, he is oriented, he is able to make his needs known. He is on nutrition, and this is kind of what made this particular situation a little bit difficult, and I'm glad that the nutritionist spoke first, and one of your panelists said something about not having interest in food. That's a huge part of this disease, and but it's also, I'm Hispanic myself, he was Colombian. This is how we love. We love through food. And it's something that I believe to be one of the most difficult things of patients that go through this. And it just, so that you know a little, in hospice, there are 3 domains that are very important to us. One being cognitive, another being nutrition, and the third functional status. And with this particular illness, nutrition becomes something very important within the structure of the family and the patient as well. And this was heavily happening in this family. So at the moment that somebody's presenting me the possibility of moving him, he was on 5 different IV medications. And just so that you know the structure of Vitas and how we work, usually when we have a patient that's on so many IV medications, we would like to transition them to a unit. We have 5 different units in Broward County. And our desire in doing that is to have the patients on a regimen in which it's easier to transition them home, and that way the family is able to take care of them. So this was something that was promoted for him immediately because of the fact that he was on 5 different IV medications. And those included antiemetics, narcotics. He was also very cachectic. He had lost close to 100 pounds. And he was treated in Mount Sinai with a catheter. He removed every day from his body 2 liters of fluid. He would become edematous, and they placed the catheter so he could drain it, and it was like everything that he put in, he would definitely put it out. So he was, and this is very common in these type of patients, we run into issues with fluid balance, essentially. So he was on Clinimix, which was running 24 hours. And I want to mention something very important because all of this comes into play. And as a result of the hurricane in Puerto Rico, there's plenty of pharmaceutical companies there that provide normal saline and these nutritions, the TPNs, the Clinimixes. So there has been a nationwide decrease in the supply of this, as well as opioids, okay? So obviously, when you see patients on TPN, it's much easier to put them on TPN if they're in a hospital. Because if I have less supply, I'm going to give it to the people that need it the most, and hospitals are the immediate chain. So as of now, it's getting a little bit better, but that was the situation at that time. We couldn't give him TPN because they would only provide us with Clinimix. But it's important to know the difference between these two is simply lipids, and you're already in a state where you're not receiving enough nutrition. So again, I go back to the Kubler-Ross stages, and this particularly looks like bargaining. I'm running this 24 hours, but I'm also removing 2 liters. It becomes something that it's my own journey, and this is what I need at this time. And that's what I think is very beautiful about palliative care and hospice, is that no matter what idea we have of how the plan of care should be for our patients, they decide. But we walk along with them. So needless to say, this is already, by all the things that I'm saying, a very difficult transition from hospital to home. Very difficult. And it's not every day that the medical director is called to see this patient. So I became his doctor, essentially. It took us close to a week and a half to move him from the hospital to home. Why? He was able to eat pudding and Jell-O, things of the sort. Along the line, somebody told him, and again, I'll go back to what the nutritionist said, small portions. Never did she say, don't eat. And that's something that I, in particular, and specifically with gastric cancer and every chronic illness, if there is an ability to eat, we will promote it. We have to promote PO intake. It's the only thing that will help us. So again, we go back to the bargaining. There were some things that he was comfortable eating and some that he didn't. In Mount Sinai, he was told that everything that was grainy, that was the word that he used. So he would say, so if strawberries, fruits that have a lot of fibers, and those accumulate in the juncture between the stomach and his duodenum, and he kept on saying this, and it'll accumulate and it'll block it. That was his fear. So he himself determined what was able to contribute to that block and what wouldn't. So Remeron at night didn't contribute to that. But then antiemetic that dissolved sublingually did. So again, we were kind of coming to an agreement as best as we could. So we continued some of his IV medications, specifically the antiemetic. He had a PICC line. In hospice also, we have different levels of care, and particularly continuous care. So in his case, you're in the hospital, you moved home, and we're going to send LPNs around the clock because there are symptoms that we need to take care of. So we provided that higher level of care for him. Now, at this point, he's particularly weak, but he's independent of what we call activities of daily living. So he can bathe himself, he can groom himself, he can do all these things, but he's very weak. Another important part of this that I want to include is the family structure. So he's an assistant. He's an assistant to a mechanic. Recently came back from Colombia. He lives in a townhome with his sister, his mother and father, and his sister has a 4-year-old child whom he's very close to. She's the only person that I see him interact with, and he's not mad. So that was something that we observed initially when we went in the home. On physical exam, he is very edematous. He's swollen. And he's discharged, like I mentioned, 5 IV medications, and we changed TPN to Clinimix and provided continuous care. Now, he had a bunch of medications for pain, including a fentanyl patch, and I know most of you are not familiar with these types of medications, but I'll tell you this much about a fentanyl patch. You have to have fat in order to absorb it. I don't know if you remember, but I told you that he lost a lot of weight, right? He was very cachectic, but he had that patch on him. I can only assume that the reason that he had that patch on him is because he met with a doctor that, you know, didn't want to get in the dynamic of, I don't want to take pills, I don't want it, so they just put on a patch so that they can address that. We placed him on a morphine pump so that he can receive that continuously, and our plan is always to just consolidate all the narcotics into one. Some of the medications that he took were Restoril, Dilaudid, Protonix, and again, most of these he wasn't taking it because he only liked the Restoril at night. That's one of the pills that he was able to take. So he's refusing PO and rectal routes. So again, rectal, he was very opposed because you try to figure out what's best for the patient with his own limits, right? So I was like, well, we can use the rectal route. I can depend on that. And he quickly said, I don't want anything up there. So that was out of the question. So we began to transition his drip that he had, his morphine drip, to methadone. And this was, again, we're working on the premise that all these medications that come in a solution bag, it's very difficult for us to obtain because there's a lack of production because of a catastrophic event that none of us can really control. But I was able to approve his Clinimix for close to 10 days, so that was a huge victory. In that first visit, all of a sudden, so one of the things that as palliative care and hospice physicians that we are told or trained to do is whenever we're having a conversation with a patient, it's very unnatural to have a conversation when I'm in the doorway of a hospital, almost trying to leave, right? They tell us to be eye level with the patient. So I was in the family room and I was eye level with the patient sitting down. And we start talking about this transition of his, particularly we were talking about the Clinimix and what we were gonna do about it. Because I saw him edematous and you're already removing so much fluid. So I questioned whether he was tolerating it at the time. So immediately when we start the topic, and mind you, we've been working on this for a week and a half, so I had many nurses tell him that we're gonna have goals of care discussions. Goals of care discussions mean that we will assess whether you're tolerating this nutrition and we will make the decisions moving on accordingly. So he became very mad and he said, I was promised that this was gonna be continued. And very mad. Mom became very mad, and all these people that went into the hospital told us that this would be happening. And I just sat there and heard them. So 4 individuals just giving it to you, right? And I said, you know, I think we should definitely pause right here. We won't make any changes right now, and I'll come back. So one of the things when you have continuous care is that a physician, that's like our ICU level. So a physician is supposed to go there 3 times a week. So I sense so much psychosocial strife in this situation. That second visit, I had to go with the social worker, with the nurse, like all of us as a team to see how we can help this family. We started to notice verbal abuse. He was being very verbally abusive to his mom in front of us. That transitioned into verbal abuse to our nurses. And again, we're blessed to be able to be allowed in the homes of these patients and families during probably the hardest times that they will have. So we tried to provide the support, and social work was a huge part of that. So we began transitioning him to methadone, get him away from the IV pump, and he's doing a little bit better. All of a sudden, in a week under our care, he lost significant amount of weight. And this happened after, he said one day, he was very weak this day. It was less and less confrontative as it transitioned, because he was getting very weak. He didn't even have the energy to really discuss the nutrition or anything of the sort. So he said, I remember when I was on TPN that they placed me on 12 hours on and 12 hours off. And I was like, so what does that mean to you? I think he was kind of understanding, yes, definitely, his level of fluids that he wasn't managing correctly. So we placed him on the Clinimex, 12 hours on and 12 hours off. In that week, he lost drastically amount of weight, and we spoke to him, and he said that he thought it was because we had cut his nutrition into half, but that he wasn't angry about it at all. I did a hemoglobin just to check. He's very weak, and he met criteria to go to the unit. He died within 3 days of transfer to the unit. But these are the visits that we did during this time, 16 in total in a 3-week period. 2 by the chaplain, 11 by the RN, 4 by myself, and social worker 4 times. But essentially, nutrition becomes something that's very, very important. Like I mentioned before, I believe that, and it's something that we're taught. You promote PO intake as much as you can, but we're also shifting between these stages of acceptance, denial, and we have to respect that journey, and it's the patient's journey. And one of the last things I spoke to Mom was she was having caregiver burnout, and she was so tired. We transferred him to the unit on Thursday. She left to Colombia on Wednesday, and he passed on Saturday. I believe that everybody needed that transfer to the unit. The patient needed it, Mom needed it, and what we knew was going to happen happened, but we respect this journey, and are very happy to be a part of it. But nutrition becomes very, very, very difficult topic at the end of life in this particular illness. So that's pretty much.
Okay, thank you very much.
Yeah.
So please join our panel. We're a little bit behind here, so I'd like a little change in the agenda. We have Dr. Rochelle Clarke, who has joined us today as well. I'm going to start off with you a question. Is there a resource to find a psychosocial expert in my area to help me?
There are resources that are available. If you go online and just do a simple engine search of psychosocial, medical family therapists, social workers, mental health clinicians that specialize in oncology or stomach cancer, you'll be able to find a list of different people that are able to assist.
Great, thank you. Here's another question. Does anybody have a question in the audience? Please let us know. What are some strategies to be balanced or organized in trying to keep appointments, family life, and other obligations going? I'll ask the same question to Rochelle. Yeah, Dr. Clarke.
So some of the strategies are to create a calendar and decide when are your best days? Are the mornings best for you, or are the evenings or afternoons best for you? And I wrote some things down here too. And make a list of some of those activities that you can complete in a day. We're not asking you to complete all of them, but there may be 2 or 3 things in a day that you can complete, because you still want to have a sense of satisfaction at the end of the day and accomplishment. And also allow your family members and your friends to support you when they can. So if there are things that you have to do throughout the day and you find that it's becoming overwhelming, ask someone to assist you with that. People like to feel like they're helping, and oftentimes we think that we can go through these things on our own, not asking for help. And make sure you maintain dialogue with those that are close to you, just so that they know what you're experiencing or how they might be helpful.
Great, thank you. I'd like to ask Pepita, how did you learn, how did learning about having cancer, your father having cancer, impact you and your family, and what did you do to cope?
What we did to cope is to communicate. I lived here, so my father came to live with me here in Florida to get care. My brother lived in Boston, but my brother constantly kept in touch with us, and he would come in. Whenever I needed a break, I would call him and say, you need to come take care of Dad, because as a caregiver, and I was talking to somebody in the audience today also, you need your time. You need to be at your best to take care of someone else, because there's no way you can be run down, angry, and not in a good mood to try to help someone else who really needs you and needs your care. And as she said, make a calendar. And what time is the best? Is mornings the best? Is evenings the best? That all comes into play. But communication and getting help, asking for help, is a huge, huge thing.
Yeah, thank you for that. Joan, in 2 sentences, can you give any tip that you can give to patients or caregivers? Either a patient or you're a patient yourself. Any one tip that you can give to patients out there when it comes to coping with what you went through?
I think that it's real important to keep as active as you can, to get back into life. And what you said about keeping a calendar, if morning is your best time, then get up and go out in the morning. My husband, who is my caregiver, who is absolutely wonderful, we go out to lunch every day. Every day we go out to lunch. That helps me be in a different place. It's more exciting. I like to eat more when we're in certain surroundings. So it's things like that that are important to keep as active as you can.
Great, thank you. Well, if there are no more questions from the audience, thank you very much to our psychosocial support panel. Thank you very much.